Today, IV ketamine versus esketamine, what the evidence actually shows and what it doesn't. A patient asks you, should I try IV ketamine or Spravato? The uncomfortable truth, there has never been a head-to-head randomized trial directly comparing them for treatment-resistant depression. Every comparison is indirect. Ketamine is racemic, half S-isomer, half R-isomer. Esketamine, the drug in Spravato, is the S-isomer alone, roughly 3 to 4 times more potent at the NMDA receptor than the R-isomer. IV ketamine is racemic. It contains both isomers. Esketamine was developed specifically to target NMDA more potently. The R-isomer may have distinct neurotrophic activity that esketamine does not capture. For esketamine, the Transform trials showed roughly 45 to 50% response at 4 weeks with maintenance dosing. Sustain 1 confirmed ongoing maintenance was necessary. Patients who switched to placebo relapsed faster. For IV ketamine, response rates of 50 to 70% at 24 hours in randomized trials. They look roughly comparable acutely, but maintenance is critical for both. Safety profiles overlap but differ in degree. Dissociation is more common with IV ketamine at full antidepressant doses. Esketamine shows dissociation in roughly 20 to 30%. Blood pressure elevation occurs with both. Bladder toxicity is seen with chronic ketamine, not esketamine at standard doses. Both are Schedule III controlled substances. Esketamine has mandatory REMS monitoring, IV ketamine does not. Spravato requires Spravato REMS enrollment, a REMS-certified setting, 2 hours post-dose observation, blood pressure check, a companion required, no driving until the next day. IV ketamine is off-label for psychiatric indications. No mandated REMS program. Clinics follow their own protocols. The regulatory burden is substantially higher for Spravato. The evidence paths diverge beyond MDD. For bipolar depression, IV ketamine has stronger evidence, multiple randomized trials. Esketamine's bipolar application was denied by the FDA in 2022. For PTSD, both have insufficient evidence. For active suicidal ideation, esketamine has FDA approval for MDD with acute suicidal ideation or behavior. IV ketamine also reduces suicidal ideation, but without an FDA psychiatric indication. Spravato costs roughly $1,500 to $2,500 per dose, though Medicare Part B covers it and some commercial insurers have added it to formulary. IV ketamine runs roughly $400 to $1,200 per infusion, typically self-pay. Insurance coverage for IV ketamine is generally more challenging. Choose Spravato when REMS monitoring is needed, insurance coverage is available, patient prefers a nasal route, or FDA-regulated maintenance is desired. Choose IV ketamine when esketamine has failed or is not tolerated. Broader off-label coverage is needed for bipolar depression or acute suicidal ideation, or access to REMS-certified clinics is limited. 3 takeaways. No head-to-head trial exists. Claims of clear superiority are not evidence-based. Maintenance matters for both. The choice is a clinical context decision. Access, off-label needs, patient preference, and monitoring burden should guide you. Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.